Out of all the areas that we could have chosen to focus on within OD, what organizational changes or organizational needs drove you to focus on change management first?
I think that Mercy being a leader in the healthcare industry, I saw a real need to continue to be able to continue to lead in that space. And as our senior leaders say, not follow along, but just like the Sisters of Mercy before us, really kind of pioneer the way that with the amount of change that we're experiencing in healthcare in the country and the massive ways that Mercy is pioneering new ways of caring for people, that we really needed to beef up our tools and keep current with our approach on how we did that. So one of the things that we did was use a tool in the methodology called the Implementation History Assessment. Mm-hmm. And it really asks people from their own personal experience of working on projects at Mercy, to rate on a scale, and then after having 116 respondents in our first year, what it showed is that for the most part, people gave us a low to moderate success rate based on their past history.
Early on in Care Evolution, we stubbed our toes many times introducing change, and we partnered with our TDO friends at the ministry office, and we learned about AIM. And AIM ultimately helped us learn how to introduce change in a way that maintained the dignity and respect of all those impacted by change.
So for Pathways in general, over the 2 prior fiscal years that we have most recently experienced, which would be fiscal year 16 as well as our fiscal year 17, we experienced approximately $14 million in direct variable cost savings opportunity during FY 16, and then $17 million approximately of direct variable cost savings opportunity for fiscal year 17, the one we've just recently completed. And certainly within both of those fiscal years, we were applying the AIM methodology to the pathway conditions that we've implemented, and would attribute a portion of that cost savings to the implementation and use of the AIM tools.
We've gotten a lot of positive feedback from nursing. I'm very excited to say that Epic, our vendor, was on site, and they had a lot of positive comments about the care plan. And we have Joint Commission has been in several of our Mercy facilities, and we've gotten very positive reviews on the care plan project. Joint Commission asked us just recently, because of Mercy St. Louis, if we would write up something for their website on our process improvement with care plans. So I think that's like a big win to show that that our nurses are communicating to them that these care plans are better and that they work, and that Joint Commission recognized that our process is providing value to the nurse and the patient.
There's another piece of Qventus that we're utilizing where we utilize that data to try to see if there is money to be saved in what we're doing, and try to identify inefficient processes. So in every ED, we have a group of the physician leaders and the nursing leaders sit down and try to identify, okay, what are those lab tests maybe that we don't need to order anymore, or we can reduce their usage. And we've identified several lab tests that we've targeted now that we think we could eliminate their usage or reduce their usage. The own local groups of physicians and nurses have identified these, and so we're merely kind of giving them feedback as to their usage of them. And we've been able, on some of those tests that I've mentioned, we've been able to decrease their usage by 40%. And that's ended up with a overall saving in charges of between $2 and $3 million.
After we leveraged AIM, we were able to see sustainable length of stay improvements for our patients. That means patients are not staying in the hospital any longer than they actually need to. We have lowered length of stay by half a day, and we've seen patient outcomes and patient satisfaction as well improve, where Oklahoma City started in the 50th percentile And this past quarter, we're inching towards the 85th percentile in inpatient overall quality of care and inpatient teamwork as well.
In fiscal year 17, we actually experienced an 84.5% increase in referrals over FY16 and over 40% increase in total ambulatory encounters. And that's only our clinic work. But it's because they've been able to focus their work on where they need to be.
I think for our team in working with Pathways, Order Set, and other clinical content is really the process in which we identify true sponsorship of the work. So being sure that we know who the authorizing sponsor of the work is, as well as the reinforcing sponsors, which with our Mercy Physician Specialty Councils, oftentimes we're able to identify those through that leadership structure, and then being able to apply the methodology in terms of what specific activities do we need the sponsors to execute, whether it be an administrative senior leader or a physician leader that really can't be delegated. It really creates a framework of expectations at each particular role, that when you come to a project and you understand the AIM principles and you understand your role in that project, you kind of know what your standard work responsibilities are, and then it creates a situation where when all of the key players and roles know what they're supposed to do, it just moves smoother.
So for us, it was key to get executive sponsorship. It was key to have a communication plan, and it was key to develop target readiness. Those were our biggest pieces of change management that made this possible.
We learned quickly that it's better to actually spend a lot more time on the front end planning than just seizing an opportunity and striking when the iron's hot, and really to go slow, in order so we can go fast in any given initiative.